Hi all. In this section, I teach you about hemodynamic monitoring. As you everyone know, hemodynamic monitoring is a process of analyzing the cardiac function by certain invasive procedures. That procedures are intra-arterial blood pressure monitoring, central venous pressure monitoring, and pulmonary capillary wedge pressure monitoring. We can see more detail about that. First of all, what is hemodynamics? Hemodynamics is the intravascular pressure and the flow occurring when the myocardium contracts and blood is pumped via vascular system throughout the body. This is what we say hemodynamics. The basic principles are blood flow throughout the cardiovascular system from area of higher pressure, that is what the basic principle, higher pressure to area of lower pressure. The pressures created by cardiac cycle, that is systole as well as diastole. Systole, otherwise we say depolarization, and diastole is repolarization. Then pressure, that is a cardiac chambers and vessels will generate certain level of pressure to maintain the normal hemodynamics. This is a picturization where it shows the average normal intracardiac and vascular pressure. So in the right atrium, if you see in the right atrial pressure is 0 to 4. It varies with the respiration. The right ventricle, the pressure is 25. The systolic blood pressure, here it is. Sys in the sense systolic. Okay. Dias in the sense diastolic. Okay. So right ventricle, the systolic pressure is 25 millimeter in mercuric level and diastolic pressure is 4 millimeter in mercuric level. Then in the pulmonary artery, this is a pulmonary artery. Here the pressure level is 25 mmHg, that is systolic level, and the diastolic is 10 millimeter in mercuric level. Then left atrium, the pressure is 8 to 10 millimeter mercuric level, and the left ventricle, the pressure is 120 is the systolic and 10 is the diastolic. Whereas in the aorta, the systolic pressure is 120 millimeter mercuric level and the diastolic pressure is 80 mm in mercuric level. So this aorta pressure, that is what our systemic pressure, that is 120/80. Then hemodynamic monitoring. Two major categories are there. That is non-invasive hemodynamic monitoring is the first category. The word non-invasive itself, it is denotes taking a blood pressure or a pulse manually, because we are not puncturing anything from through the external body surface. We analyze the blood pressure and other parameters. That is what the non-invasive method of monitoring hemodynamics. Next is the invasive monitoring. Invasive monitoring is mainly three types are there. First one is intra-arterial blood pressure monitoring. We will detailedly see in the other slides. Okay. Then next is a central venous pressure. Otherwise we say CVP catheter, and pulmonary artery catheter. Otherwise pulmonary artery wedge pressure monitoring. These are the three invasive methods. Detailedly we see about the invasive hemodynamic monitoring. In the invasive hemodynamic monitoring, there is three components are there. That is transducer, amplifier, and monitor, otherwise recorder. Transducer is, that is, convert the fluid waves. That is a basic principle there. Converts fluid waves in the electrical signals. Then the amplifier, which increases the size of the electrical signals, and the monitor recorder, it display the signals and save the data. Specialized equipments which are used for invasive hemodynamic monitoring are, first one is the catheter access to client. The catheter access, that is, for example, if it is an intra-arterial blood pressure monitoring, means we insert a arterial cannula in the radial artery, especially radial artery, or any arterial line we generate. Then central venous pressure, in the sense we insert a catheter in the external jugular vein or internal jugular vein, any vascular access, venous access we create. Then next is a semi-rigid high pressure tubing we use. That is a three-way stopcock, intra-flow or inline flow device is there. Then third is the inflatable pressurized sleeve or bag. So that is the bag. In that bag we insert the IV solution, especially 0.9% normal saline solution with the heparin is added. That is what the general standard practice. Continue with that. Next is a calibration equipment. Calibration of equipment in the sense we usually do leveling and zeroing. In between the monitoring times, we do the leveling. Leveling in the sense the transduced at the level of right atrium, and zeroing in the sense atmospheric pressure. We just refreshing the pressure level with the atmospheric pressure. This is a calibration of equipment. First, we already said which are the invasive method. The first one is intra-arterial blood pressure monitoring, usually denoted with the A line, otherwise the IABP. So in this picture, this is the picturization. In this the line is the inserted in the radial artery. So further it is connected with the transducer, and further this is also a pressure bag where IV fluid is inserted and also a pressure gauge is there. We see detail. So arterial blood pressure, that is an arterial line is nothing but an invasive method to measure the blood pressure, that is intra-arterial blood pressure. The indications are, so it is indicated for direct continuous blood pressure monitoring in the critically ill patients. Especially we measure systolic, diastolic and mean arterial pressure, allows for serial sampling of ABGs, and considered it is a low risk and more accurate than cuff pressure in low cardiac output and patient with shock. Never used to give medication. These are the indication in the sense which are the situations we use intra-arterial line or intra-arterial blood pressure monitoring. So especially for example, through this we can collect the systolic blood pressure, diastolic blood pressure and the mean arterial pressure. Similarly, certain patients in the critically ill situation, they need to do serial of arterial blood gas analysis. So, periodically we are supposed to, in a situation, to take arterial blood sample. Such patients also, it is an indication for we can do a intra-arterial line. Then, also it is a low risk for the performing the procedure. Then, we get an accurate blood pressure when the patient is in shock stage or when the patient have the low cardiac output. Such situations, if we are measuring intra-arterial blood pressure, we get a real-time genuine reading. Then the thing we supposed to make sure is never give medicines in the arterial line. Then arterial line monitoring site. First one is a radial artery. Considering the radial artery, it is a low complication, and here we supposed to perform Allen's test prior to prefer the radial artery. The reason is Allen's test is the test which we use to determine the patency of ulnar artery. Why means when we are puncturing radial artery, there is a chance of damage to the radial artery. So to maintain the peripheral perfusion, we should make sure the ulnar artery is patent. Then next site we prefer is ulnar artery. Primary source of hand flow and low complication and median nerve damage is expected. Then brachial artery, medial to biceps tendon. Then potential median nerve damage is there. Then axillary artery at junction pectoralis major and the deltoid. Axillary site which is safer than the brachial and low thromboembolic issues. Next is femoral artery. It is easy access in shock stage. Potential hemorrhage or local retroperitoneal hematoma or hemorrhage is the risk for that, and it requires longer catheter. Then what is Allen's test? Already I said we perform Allen's test while prefer the radial artery. So in Allen's test, we occlude the ulnar and radial artery and tell the make the patient to make a fist until the hand seems blanched. Once we make sure it is completely blanched and we release the ulnar artery first and make sure there is a perfusion within 5 seconds. Then we can confirm there is a ulnar artery is patterned to maintain the peripheral perfusion. Then what are the contraindications for that? So if there is a inadequate circulation or infection at the site or recent cannulation of same artery means it is contraindicated to insert the intra-arterial line in the particular site. Then arterial pressure tracing. This is the graphical presentation which shows the arterial pressure tracing. This is a wave for that. This is a as usual ECG wave and this is the arterial pressure wave. The arterial pressure mainly there is, you can see that this is the aortic valve opens. Okay, it will start a high when aortic valve opens and it is further it increases with the pressure increase as blood flows in the aorta and it reaches the maximum peak level at the maximum systolic pressure and it is started to decline as aortic valve closes and a minimum diastolic pressure reaches the base level. This is the waveform of intra-arterial tracing. Okay. So while comparing with the ECG wave, you can compare that QRS, that is a QRS wave with the corresponding arterial waveform. As it is, the QRS wave, there is a ventricular depolarization, this is ventricular contraction. During this time, there is a waveform started. Then during the systole, it is reaches the peak level and the end of the diastole, it reaches the baseline. Then certain troubleshoots. What are the troubleshoots associated with the intra-arterial line monitoring? First of all, loss of waveforms. In which are the situations that there is a loss of waveforms? We cannot assess or we cannot recognize waves. This is stopcock. If the stopcock is kept closed, then there is the absence of waveform. Then another situation is monitor is not on the correct scale. Then also it leads to loss of waveforms. Other factors that leads to loss of waveforms are non-functioning monitor, non-functioning transducer, kinked or clotted catheter and asystole. These are the certain reasons the monitor shows loss of waveforms. I repeat it. First of all, the stopcock is closed, then monitor not on correct scale, non-functioning monitor or non-functioning transducer, and kinked or clotted catheter and asystole. Asystole in the sense absence of electrical activity in the heart. These situations, monitor shows loss of waveforms. Then dampened waveform. Dampened in the sense that is a here in this picture you can say over dampened waveforms. What are the situations or what are the causes that leads to over dampened waveform? That is air bubble or blood in the line, that is in the transducer line. Then if there is a presence of clot or disconnected or loose tubings, under inflated pressure bag, then catheter tip against the wall or complaint tubing. These situations that leads to dampened waveform. Then under dampened waveform. This is a picture that shows the under dampened waveform. The reasons are too many stopcocks, long tubing, air bubbles and defective transducer. Next we see what are the complications and what are the nursing considerations. The first see about what are the complications. The complications are thrombosis or emboli. As it is the long term the intra-arterial line is there, the risk of emboli formation or thrombus formation is small. Then hematoma, that is as the intra-arterial hemorrhage or escape of blood into the cells that leads to hematoma formation. Then infection, nerve damage or palsy, that is paralysis may occur. Then if it is a disconnection of the two, means that leads to blood loss, otherwise we say hemorrhage. Then fistula, abnormal connection between arteries or veins may be happen. Then aneurysms, aneurysm in the abnormal dilatation of artery. Okay. Then digital ischemia, these are the complications due to intra-arterial line. Then nursing consideration, what is the role of nurse? Monitor for complications, always see whether any complications, already seen the complications and we are supposed to monitor. Close monitoring should be done for the patients on intra-arterial line, any kind of invasive lines. Then compromised blood flow to distal extremity, that is what we are supposed to check the distal pulse. Okay, so then only we can make sure whether any damage to the arterial line or is there any compromised blood flow, that is thrombosis or arterial spasm. Then insertion size should suppose be checked for infection, bleeding, hematoma or skin breakdown. Then maintenance of system, sterile dressing changes, tubing, caps and flesh bag changes. The next we see about the central venous pressure monitoring, otherwise it is a CVP monitoring. In the central venous pressure monitoring, it measures the pressure in the right atrial pressure, and it is used to assess right ventricular function and venous blood return to the heart. Then central venous pressure or right atrial pressure, it is a reflection of the right ventricular filling pressure, that is preload, otherwise right ventricular preload. The normal limiter is 2 to 6 millimeter in mercuric level. When the CVP increase, otherwise central venous pressure increase when there is a fluid overload, otherwise the excess fluid accumulation in the right ventricle, this situation there is a increased central venous pressure. And the situation where the decreased central venous pressure is hypovolemia, there is a decreased right atrial or right ventricular filling. Then what are the indications for central venous pressure monitoring? First is cardiac disease, next expected volume shift, hypovolemia, shock and massive trauma. In these situations we administer, otherwise we monitor the patient's parameters through the central venous line. Here we see what are the central venous pressure placement site and each of the benefits and risks. The major sites we prefer are right jugular, internal jugular vein, external jugular vein, subclavian vein, antecubital vein and femoral veins. So here see what are the each of the site, its benefits as well as risk. First of all, right internal jugular vein. The benefit is it is a easy accessible landmark, and the risk associated are carotid or brachial plexus trauma and pneumothorax. Then second is external jugular vein. It is a superficial and safe site for inserting the central venous line. Then risk are, it is a low success rate, sheath kinking is possible at subclavian vein and subclavian trauma is chances are there. Then third is a subclavian vein. It is an accessible and good landmark. The risk associated with subclavian vein are pneumothorax, hemothorax, chylothorax and pleural effusion. Followed by the antecubital vein. Antecubital vein, the benefit is it is low complication rate, but the risk are it is the lowest success rate, thrombosis or thrombophlebitis is possible and catheter shearing is possible. Then femoral vein. The benefit is it is a high success, but the risk is sepsis and thrombophlebitis. Then it is a central venous pressure waveform. So in this picture you can see that this is the electrocardiograph, that is a ECG wave, and this is a central venous pressure wave. Especially here we note the A wave, C wave and V wave. A wave represents right atrial contraction. After P wave of ECG, we can visualize the A wave. Then C wave, this is closure of tricuspid. So comparing with the electrocardiogram, it represents near end of the QRS complex. and V represents the atrial filling or tricuspid valve closed. So early T and P interval, we can visualize the V wave. This is what the comparison with the ECG as well as the central venous pressure waveform. So we can see the troubleshoots associated with central venous pressure, that is a high readings and low readings, and also we see what are the complications associated with the CVP monitoring and what is nursing care. The high readings, which are the situations it shows high reading in the sense when there is a ventricular failure, that's it, right or left side ventricular failure, superior vena cava obstruction, tricuspid regurgitation, then cardiac tamponade, pulmonary artery hypertension, overload and glomerulonephritis. These situations that leads to CVP readings will be more, that is high. Then the situations where the low reading shows are vasodilation, hemorrhage, hypovolemia, Addisonian crisis, sepsis, regional anesthesia, polyuria and sympathetic dysfunction. Next is the complications. Which are the complications we can expect when the patient is on central venous pressure catheter? That is arterial puncture. If there is a chance of arterial puncture, then patient present with the hematoma, false aneurysm and fistula. Then catheter position during placement, valve perforation or tamponade and dysarrhythmia. Then catheter shear, brachial plexus injury and thoracic ductal injury are chances are there. Then what the nursing care? What is the role of nurse? So sterile dressing changes supposed to be done. Aseptic techniques should be maintained while changing the dress because there's a risk of infection is more. Tubing cap and fluid bag changes. Periodically monitor the fluid bag as well as check the transducers, fluid bag pressure and change it appropriately. Then flushing of lumens to prevent the clotting, otherwise to maintain the patency of arterial line, periodically flush the line with normal saline or heparinized normal saline. Then never tie off, in the sense never tie it, that will lead up with the complications. This is a triple lumen or double lumen catheter we use for the central line. This one shows 7 French 20 cm triple lumen and 5 French 8 cm triple lumen and 4 French 8 cm double lumen. The third invasive monitor, otherwise third monitoring, is a pulmonary artery wedge pressure monitoring. In short, we say PAWP. So the picture itself you can understand that there is a transducer is there, then pressure bag is there, then finally this long catheter is inserted to the right atrium, right ventricle, then reach the pulmonary artery and we read the pulmonary artery pressure. The significant feature of pulmonary artery catheter is it is used to assess left ventricular function, as well as it is known as it is a multitasking catheter. Why it is says multitasking catheter? In the sense it is a long catheter we insert. Throughout this we can analyze the right atrial pressure, we can analyze the right ventricular pressure, as well as we can analyze the pulmonary artery pressure and pulmonary artery wedge pressure, and we can analyze the left ventricular function. Then there is what right atrial pressure, same as central venous catheter. There is we can measure the right atrial pressure. Pulmonary artery, in the pulmonary artery we can analyze pulmonary artery systolic pressure, pulmonary artery diastolic pressure and pulmonary artery mean pressure. The left atrial pressure, there is pulmonary artery occluded pressures, that is normal limit is 5 to 13 millimeter in mercuric level. The reflection of left ventricular filling pressure, that is what the preload. Then pulmonary artery catheter, already said it is a multitasking catheter. We can analyze the intermittent cardiac output. The specialized pulmonary artery catheters, the additional features are we can perform continuous intravenous infusion and continuous cardiac output monitoring, continuous venous mixed oxygen saturation monitoring, that is, which represents venous blood saturation from many body tissues, and we can monitor the balance between oxygen supply and demand. Then temporary transvenous pacing wires. These are the additional features or the additional things we can perform when the patient is on pulmonary artery catheter. Then insertion site, internal jugular vein or subclavian vein is most preferably used. Then threaded into right atrium to right ventricle, finally resting in the pulmonary artery. Before the procedure, we are supposed to perform chest X-ray, and after inserting the catheter also we take the chest X-ray, make sure the catheter is placed in the proper place, and rule out any pneumothorax or hemothorax, because the expected complication is pneumothorax or hemothorax. So before using the catheter for any reading the measurements or any IV infusions like that, we are supposed to make sure the exact position by take chest X-ray. This is what the pulmonary artery catheter. There is a catheter we use. The name is Swan-Ganz catheter. Okay, the name of the catheter is Swan-Ganz catheter. It has the following parts. That is a distal lumen, the pulmonary artery. The tube itself, we can see the markings or the which are the areas or names it is there. The proximal lumen is central venous pressure port. Then inflation balloon, thermostat lumen, additional lumen. We can see that, okay, this is the tip of the catheter. Then bands of the balloon. This is the thermocouple wire on the surface of the catheter. Then this is the balloon inflation port. This is the proximal injection port. This is the pulmonary artery distal port. This one is we connect to the computer or the monitor. Then right ventricular pacing infusion port. This is the proximal injectate output. Then right ventricular pacing infusion output. That is why it is a multi-perform catheter, and we can use it for various purposes. And then next, see what is a pulmonary artery catheterization in this. What is the indications and what are the informations we derive from the pulmonary artery catheterization. The indications like established diagnosis of shock or respiratory failure, gate therapy of shock or respiratory failure. We can measure right atrial pressure. That is something similar to the central venous pressure. Then assess blood volume. It reflects the preload to the right side of the heart. And assess right ventricular function. Infusion site for large fluid volume. Infusion site for hypertonic solution. These are the indications we can use for the pulmonary artery catheterization. Which are the informations we can derive? The direct measured in the sense central venous pressure we get, then pulmonary artery pressure, saturation, oxygen saturation level, then cardiac output, and also pulmonary capillary wedge pressure. These are the direct measurements we get from the pulmonary artery catheterization. Then what are the calculated measures? They are systemic vascular resistance, pulmonary vascular resistance, stroke volume, and oxygen delivery. This is a picturization more clearly shown what is a catheter. This is the pulmonary artery catheter, which is inserted through the superior vena cava. It reaches the right atrium, right ventricle, then the pulmonary artery. Then further it has each of the port. There is a distal pulmonary artery port, proximal CVP port. Then this one connect to the oximeter. This one the cardiac output connector, optical module. Then here monitor connecting cables. Then this is a transducer, that is a pressure bag as well as the heparinized IV solution. This is the important aspect. What are the complications we can expect when patient on pulmonary artery catheterization, and what are the nursing care? The complications like pneumothorax, hemothorax, hemorrhage, cardiac tamponade, then vessels like right atrial, right ventricle perforation is there, arrhythmia, air embolism, pulmonary embolism, thromboembolism, and infections. These are the very simple terminologies. Then what are the nursing care? So always keep sterile dressing, then tubing, cap and fluid bag changes periodically and as indicated. Then flushing of lumens, that is to prevent the blockage or to maintain the patency of the artery, that is a line. We have to flush it with a heparinized solution and never tie off. With this completed the hemodynamic monitoring, that is especially discussed about the invasive methods of hemodynamic monitoring, that is pulmonary artery wedge pressure monitoring, central venous pressure monitoring, and intra-arterial blood pressure monitoring. I hope you understand, you got a good idea about hemodynamic monitoring, and keep subscribe the channel. Thank you.